Today I'm going to go over how to view an MR Enterography. So this is one of our most specialized MR exams. The indication is almost always going to be inflammatory bowel disease, either ulcerative colitis or Crohn's disease. Less likely indications may be a polyposis syndrome or a bowel neoplasm. So we'll kind of focus on my search pattern for a patient with inflammatory bowel disease. And our goal for this exam is to relate to the clinician the burden and severity of intestinal inflammation and the presence of IBD-related complications and extraintestinal manifestations. So for this exam, the sequences are all very complementary. The beginning part of the exam relies on endogenous tissue contrast and the later part on injected contrast. And overall, we're going to be evaluating the anatomy and characterizing the tissues, focusing especially on the bowel lumen, the bowel wall, and the mesentery. So we start with our coronal T2 single shot sequence, just like any abdominal MR exam. I've said this a few times now, but go through all the upper abdominal solid organs. We don't completely visualize the liver and sometimes the spleen on an MR enterography, but we do what we can. Kidneys, adrenals, pancreas, biliary system, urinary bladder, genital organs. And then I like to focus on the bowel by working my way up from as much as we can see of the rectum to the sigmoid colon, to the ascending colon, to the transverse colon, to the descending colon. This can get kind of jumpy when you're watching somebody else, so I'll try to minimize how much I scroll through. But we can usually find the terminal ileum on this sequence. It's really critical to evaluate the TI because it's the most commonly affected segment of bowel and Crohn's disease. We can usually see the appendix. And from there, I don't follow every small bowel loop discreetly, but I like to take a quadrant approach, so I look at all the small bowel loops in the left lower quadrant, in the left upper quadrant. Here you should normally have feathery jejunum, which this patient has. These feathery bowel loops, right upper quadrant and right lower quadrant. So then we have our coronal T2 fat saturated sequence and bright blood sequences. These are similar and provide really nice endogenous tissue contrast. So you can see here, kind of jumps out to your eye right away that in the right lower quadrant there's a focally narrowed small bowel loop. This would be a mid-ileal bowel loop, and you can window it a little bit better. But the sigmoid colon here looks thick-walled, and normally the bowel wall is almost imperceptible, but here it's thick, and it has slightly increased T2 signal. It's kind of a light gray, as opposed to the normal jejunal wall, which looks really dark on T2. So this is one of the most subtle but most important findings to assess submucosal edema, which is indicative of inflammatory bowel disease, which is active. We can see this again on the bright blood sequence. It really stands out here that this bowel wall is thick and it's too bright. And we can also start to say that there's a connecting sinus tract from this abnormal mid to distal small bowel we've identified to the abnormal sigmoid colon. So this is suspicious for penetrating disease and a fistula or sinus tract. Other things that we want to look for besides bowel wall thickening and increased T2 signal in the bowel wall are luminal surface irregularity, which might indicate active ulcers, a transmural hyperenhancement, which indicates active disease, prominent small bowel mesentery visa recta and engorged vessels, which also indicate active disease, increased mesenteric fat around diseased loops, which is more of a sign of chronic disease. You can see that there is increased fat kind of separating these abnormal tethered small bowel loops out from the rest of normal small bowel. We can look for perienteric and pericolonic inflammation suggestive of active inflammatory bowel disease, luminal narrowing and stricturing, which is more of a sign of chronic disease, and that's what we see here. So this exam has a benefit of being performed over about 20 to 30 minutes. So if we see an area of luminal narrowing, we want to make sure that that persists throughout all the sequences, that it's not just transient peristalsis. So we'll check on our later performed sequences to make sure that this stays the same, which I can assure you it does. Spoiler alert. So we want to look at the upstream small bowel and see if that's dilated. In this case, it is not. If it is, then that suggests some functional obstruction, and we'd want to describe the location, the length, and the degree of that dilation. Finally, we want to assess the proximal ileum and the jejunum. Give special attention to these areas because they're not assessed very well by endoscopy. So we can provide benefit to the clinician by letting them know of any abnormality in those regions. Last but not least is extraintestinal manifestations of inflammatory bowel disease. So things like sclerosing cholangitis in the liver, cholelithiasis in the gallbladder, pancreatitis, nephrolithiasis in the bones, sacroiliitis or AVN, and then even cutaneous or perianal disease, which might not be clinically obvious but can be important. So describe or bring attention to those areas. Overall, we're giving a pretty subjective assessment of the disease burden, and we just want to describe the number of features present, their severity, and their conspicuity, because those features correlate with the level of active inflammatory disease. So we also have our bolus sequence. Make sure that the major vascular structures of the abdomen and pelvis enhance, and then we can split up our post-contrast sequences. So here I just have the pre-contrast and arterial, and areas that enhance, like this area which we've been focusing on, are suggestive of active inflammation. And if we bring up, we'll switch the arterial over here and have it delayed over here, we can see that this area, specifically the sinus tract, has even more obvious contrast enhancement as the exam goes on. And again, this area of luminal narrowing persists throughout the entire exam. So this would be suspicious for, or consistent with the sinus tract. We didn't see high T1 or T2 signal to suggest that there is fluid, making a fistula between the sigmoid and the small bowel. And then I would also suggest that there may be an enteroenteric fistula in these abnormal tethered small bowel loops. I don't discretely see a tract, but I also don't really see a bowel lumen within each loop that's discrete from another one. It seems like they all kind of flow into each other and they have a very abnormal orientation. So I would alert the clinician to the possibility of penetrating disease in that area as well. We also want to look for a phlegmon, which is an ill-defined inflammatory mass, or an abscess, which is a well-circumscribed, peripherally enhancing fluid collection. Usually those are found in areas which have considerable luminal narrowing and active inflammation, such as this.